हम्म, పడుతుంది ఇది ఆడియో మ్యూట్ చేయి కానీ వాడికి చెప్పు పెట్టాను అదేమో
మీ అందరికీ నా హృదయపూర్వక స్వాగతం. This is wishing you all a heartfelt welcome in my new language, Telugu, spoken by about 80 million plus people worldwide, and the first time that Telugu has been spoken in such an honest and sacrificial way.
Is it coming?
అంటారా ఎక్కడన్నా ఆగి చేసుకోవాలి. మొత్తం దగ్గర చూసి
After that, I'll go. శరణ్య గ్రూప్ పీజీస్ అందరినీ లాగిన్ అవ్వమని Yes,
Hello, Asha ma'am.
Yes, Tirth.
Shall we start?
Sir hasn't joined, boss, and he's not picking up the call.
juniors.
Yeah, he's joined.
Sir has joined, yes.
Have you made it live?
Yes, it is YouTube live.
Okay. Namaskar, Patel sir.
नमस्ते.
सर वीडियो ऑन करिए ना, प्रोग्राम स्टार्ट करें.
हाँ हाँ बिल्कुल.
आपसे 2 मिनट बात करना था सर मेरे को.
Oh yes.
तीर्थ, you please start the program.
Okay.
Welcome, Dr. Rekha.
नमस्ते नमस्ते.
A very good evening to present over here, respected delegates and guests. I am Tirth Shah on the behalf of Corona Remedies. Welcomes you all in this Happy Learning Masterclass webinar series in association with Karimnagar, Khammam, Mahbubnagar, Mancherial, Nalgaon, Nizamabad, and Warangal. And the theme of the today's webinar is mixed bag. This is the 195th edition of Happy Learning Masterclass. I welcome Dr. Asha Jain, convener of the today's webinar. She is a past president of Foxy. She has a Foxy recognized Center of Ultrasound Training, Colposcopy Training. Currently, she is the director of SMSA Hospital Raipur, medical director of CPRS, elected member of Medical Council. Past offices of Dr. Asha Jain is the president Raipur Obs and Gynec Society, VP at IMS Chhattisgarh, and president at Rotary Club of Raipur North. Academically of Dr. Asha Jain is training in colposcopy from AB School of Colposcopy, Chennai. Certificate and instructor in FCCS OB course, IOTA certification from IOTA Group. Field of interest of Dr. Asha Jain is the saving the uterus, fetal medicine, obs and gynec ultrasound, critical care and preventive oncology and colposcopy. So, as per our tradition, I welcome you all and join this virtual light lamping session.
बंद करो
Join this virtual light lamping session.
बंद कर दो
Now I am handing over this session
Thank
to
you,
Dr. Asha Jain,
Thank you
ma'am.
so much. Namaskar, all the dignitaries. I would like to say a few words about Dr. MC Patel, sir, the program director of Happy Learning web series, and today we are at 195. So, sir, I welcome you to this webinar for the initial welcome address before we take the program forward.
Thank you, Dr. Asha Madam. It gives me immense pleasure to welcome you all on 195th episode of Happy Learning Masterclass, and today's joining society Karimnagar, Khammam, Mahbubnagar, Mancherial, Nalgonda, Nizamabad, and Warangal. I welcome Dr. Ramadevi Madam, who has kindly consented to be guest of honor to bless the webinar. Of course, she is always with us in any of our academic activity. Welcome, Madam, and thank you for sparing time to bless us. I also welcome two
Thank you,
learned
sir.
speakers who are going to discuss very important topic for today's webinar. Dr. M. Vijayasri Madam from Khammam. She is going to discuss about abruption placenta, and to chair that very session, I invite welcome Dr. Vijaya Madam from Karimnagar, Dr. Purushottam from Warangal, and Dr. Manjula Madam from Nalgonda. One more speaker is Dr. Gaurisri Madam from Nalgonda, and she is going to discuss about placenta previa. And to chair that very session, I welcome Dr. Swarupa Rani Akula Madam from Mancherial and Aparna Madam from Mahbubnagar. And today we are going to discuss very important point, that is MTP Act and its amendment, what gynecologists should know, and it will be in a reverse panel. Panelists will be asking a question, and being a moderator, I will be answering the same. And to welcome to that very panel all the learned panelists, Dr. Rehana Begum Madam from Khammam, Dr. P. Sujata Madam from Nizamabad, Dr. Sirisa Madam from Warangal, Dr. Madhuchandar from Warangal, Dr. Meghna Rao from Karimnagar, Dr. Madhvi Madam from Karimnagar, Dr. B. Sailja Madam from Khammam, Dr. Sushma Madam from Nizamabad, Dr. Naini Srishti from Karimnagar, Dr. Mridula Mahbub from Nizamabad, Dr. Sandhya Rani Burri from Warangal, Dr. Kalluri Madam, Kalluri Radha Madam from Karimnagar, and Dr. Nilima Kasam Madam from Karimnagar. I also welcome Dr. Asha Jain, who is convener for not only for this program, but in this series since long, and two learned coordinator, Dr. Rekha Rajendra Kumar, President Bengaluru Society. She is also coordinator in this series since long, and Dr. Sujay Sri from Bhimavaram. She is also coordinator for this webinar. So in era of COVID-19, I started this program with only 3 friends. And at that time, my aim was to meet Foxian friends on virtual ground to say hello and to say discuss focused topic. But with request on part of so many of friends, we have continued this program. And I am happy to announce again, this is our 195th episode of that very series. And I see so many faces who have joined this Happy Learning Masterclass series in past also. So now they are all Happy Learning Masterclass family. And I am happy to announce once again that now we are 7,000 plus member as far as Happy Learning Masterclass web series is concerned. So with this small brief introduction of this webinar and welcoming you all, and I also welcome all the president and secretary of Joining Society and all the delegates, and wishing you all the best for this webinar, and welcoming you all again. Thank you very much.
Thank you, sir. May I have the CVs, please? So I would like to introduce the coordinators, Dr. Sujayshri and Dr. Rekha Rajendra Kumar ma'am. Dr. Sujayshri is a young dynamic gynecologist, the founder secretary of Bhimavaram Society, doing IVF, does a lot of community work as well, and her interest is in fertility and good quality obstetrics, even at the periphery. So welcome, Dr. Sujayshri. May I have Rekha ma'am's CV? Rekha ma'am is the current president of Bangalore Obstetric Gynec Society. She is also a great teacher, has many awards, writes a lot of articles, and is a practicing gynecologist for the last 32 years. She is President BSOG this year, and she has a lot of work in Foxy and in Kasoga as well as in Bangalore Society. So welcome, Dr. Rekha. The
Thank
third
you,
CV,
ma'am.
please, of our chief guest. Our guest of honor today is Dr. E. Ramadevi ma'am. She is professor and HOD, Department of Gynae, Chalmeda Anandrao Institute of Medical Sciences. She is a laparoscopic surgeon and infertility specialist at Dr. Bhum Reddy Hospital. She has worked as APCOG General Secretary, 4th TCOG Scientific Reviewer, has many presentations in national and international conferences, and she is an examiner for UG and PG for the last 20 years and has 27 years of practice. So welcome, Ramadevi ma'am. We would like to have your blessings before we proceed for this webinar. Ma'am, you're muted, please. You're muted.
Madam, please unmute yourself, Ramadevi madam. Yeah.
Good evening, one and all.
Good evening.
Can you hear me?
Oh yes,
Yes.
oh yes, you're audible,
Yes,
ma'am.
ma'am.
I thank Dr. MC Patel sir for organizing 195th webinar, which is a wonderful webinar, sir. They're really useful to all the OBG specialists and many postgraduates. Really, it's a Great, great, great. Really, I cannot express in words, sir. Such a great going webinars. I have been following these webinars since long time, sir, since COVID, I think. I also thank all the organizing persons, Dr. Asha Jain madam and other organizers. Thank you one and all. And thank you, sir. Thank you one and all.
Thank you, madam, for sparing time to bless the webinar. Of course, you are always with us in any of our academic activity. Thank you for sparing time.
Sir, and I also request all the members to vote for Dr. MC Patel, sir.
Thank you, madam. Thank you.
I mean, such a academician and is interested in so many things. He will develop further in our Foxy, I think. Thank you, sir.
Thank you, madam. Thank you, madam.
Thank you so much, ma'am. Sir, with due permission, should we start the
Oh yes,
scientific?
oh yes, oh yes, we can.
Before that, I just would like to say only one word with the permission of sir. Sir, that it is as Ramadevi madam said, 198, it is almost close to 200. Sir has been working for more than 3 continuous years for spreading the knowledge, and each program, each webinar CME has lot of content. Other than the talk, he always makes it possible and sees to it that there are panels as well as the reverse panel, so that many of us do learn on the medico-legal aspects. Sir, otherwise also is there for help regarding the medico-legal problems to any of us in the Foxy, any of the Foxy members. So it is my request to all of you that please, please, please vote for sir, because he's been working so meticulously for the past continuous more than 3 years. So none other than sir deserves this post. Thank you so much.
Thank you. Thank you, Rekha.
Thank you so much, Dr. Rekha.
Yeah.
Thank you. So now may we have the CVs of the chairpersons, please? Dr. Rekha, would you like to read them out?
Yeah. Can I have the CVs, Mr. Tir? Yeah.
Is
Thank
it
you.
visible?
Oh yes.
Yeah. Dr. Vijaya Bharti madam, she has over 23 years of experience and 5 years of experience in infertility practice itself. Madam has a professional certification that she's trained in the medical diagnostic ultrasound in Nagoris Institute at Ahmedabad.
Hello?
She also, hello?
Hello?
Yes. Yeah. She has ART training from Rainbow IVF Agra, lot of membership from the esteemed bodies to her credit.
Okay. There is a
And-
little problem with my network issue, ma'am. That's the reason why I'm asking for that. Okay, I'll try my best.
Yeah, Madam Vijay Bharti.
Yes, I
madam
will send.
speaking.
How can I send? Can you send you a mail?
Hello.
WhatsApp? Okay. Okay, ma'am.
Dr. Vijay Bharti has academic and other achievements like Associate Professor of Karimnagar Medical College and the President of Karimnagar Society. Over to the chairperson. Can I have the other chairperson CV, or Dr. Asha you would like to take, as you say? Hello?
Please go ahead, Dr. Rekha.
Yeah. Thank you. Another esteemed chairperson who has agreed and consented, and we are so happy to have Sir Dr. K. Purushottam. Sir is the Associate Professor of Obstetrics and Gynecology from the RVM Medical College near Siddipet. He is a General Secretary of Warangal Society, President of Warangal Society, Joint Secretary of TCOG. He is also the examiner at the postgraduate and undergraduate universities. Sir is a General Secretary, has conducted state conference at Warangal way back in 2015, and he's consultant in various hospitals practicing in Warangal. Thank you, Dr. Purushottam, sir. We are happy to have you here. Sir, Purushottam, sir.
Can you hear me?
Yeah. Yes. Third chairperson.
Can you hear me, madam?
Yes, sir. Yes, sir. We are able to hear you. Thank you for chairing this session. Please stay with us, sir. 1 minute. I'll introduce the third chairperson, Dr. Manjula Rapolu. Mr. Teeth, can I have Madam CV if you don't mind?
Ma'am, I haven't received CV for Dr. Manjula.
Okay. Dr. Manjula is a very close friend of ours, and we have connected on many webinar platforms with Dr. Manjula, active secretary of Nalgonda Obstetrics Gynec Society. Welcome all the three chairpersons to take the proceedings forward. Hello, Dr. Manjula.
Hello,
Can you
ma'am.
introduce the speaker? Can you introduce the speaker?
Good evening, everyone.
Vijayashree, madam. Yeah, please.
Thank you for giving me this opportunity, madam. And also at the outset, I thank Corona people also for being instrumental in spreading the knowledge amongst gynecologists. I'm very fortunate and honored to chair Dr. Vijayashree's madam session. She is a knowledge hub actually, and she is a walking encyclopedia.
Hi, Vijayashree, madam.
Thank you,
Namaste.
ma'am. Thank you.
Namaste. Yeah, please proceed. Madam, are you sharing your screen?
Yeah, already done, ma'am. 1 second. 1 second, ma'am.
Yeah.
Is it visible, ma'am?
No, ma'am,
No,
it's not
still
shared
no.
because Corona was sharing. You need to share again.
Yeah, okay, ma'am.
Purushottam sir, would you mind renaming yourself? This is Asha Jain speaking.
Ma'am, can you see my screen?
Yes, now,
Yes,
now.
ma'am.
Yes, it is seen. Make it full screen, madam. Yes, fine.
Yeah, I made it, sir. Sir, very good evening to one and all. Thank you, Patel, sir, for giving me this opportunity multiple and number of times, actually. I'm happy to share my knowledge in this platform amidst all the learned persons. And I to learn a lot of things once I enter this academic sessions. And I'm Dr. Vijayashree, and I'll start my talk without much of delay, sir. Today, sir asked me to speak on abruption, but then I thought everybody knows how to diagnose the abruption, what are the symptoms, signs, all these things. I didn't want to go into detail. So I just wanted to share some of the things which I had some queries when I get a case related to abruption. So one by one, I thought I will clear my queries along with you people, and I gone through so many guidelines. And finally, I had made it a crispy presentation. And I'll start off with, of course, any presentation will start with a definition. We all know APH is bleeding from or into the genital tract occurring from 24 weeks of pregnancy and prior to the birth. And the main ones are placenta previa and abruption. And I'll restrict myself to abruption for today's session. The incidence, of course, it is still 3 to 5%. Leading cause of perinatal and maternal mortality. Definitely, it is a very big leading cause. So when I saw and went through the magnitude of the problem, I found globally each year, there is 50% of 5 lakh maternal deaths were due to antepartum hemorrhage. So this is a very big number, and which we need to take care of these things, and we will try to get these maternal deaths down. And not only in developing countries, it is in the developed countries too. So the etiology, other than the placenta previa and abruption, which we really take care, and many of the cases are coming to our OPD, the local causes which should not be ignored are bleeding from the vulva, vagina, and the cervix. Of course, from the cervix, it will be physiological in the second trimester onwards. But then we have to take care of the bleeding, the uterine contractions, the abdominal pain, drop in blood pressure, and back pain. We should not ignore that back pain where they'll have local causes and back pain. They still have, we have to rule out these type of causes. other than the major things. So why we are worried about these local causes too, along with abruption and placenta previa? Most of the patients, they come with spotting. That is just staining and streaking of blood. That could be a just initial part of placenta previa or an abruption. But then these local causes also should be taken care of. Otherwise, they go on dribbling, and finally they'll end up in shock by the time they come to us. We did see a handful of cases like that. Then comes the minor hemorrhage, of course, blood loss less than 50 ml that has settled. Patient also will ignore it, and second bout might be very horrified and torrential. So we need to take that also into consideration. Then comes the major hemorrhage, blood loss 50 to 1000 ml. Why I made it 1000 ml is more than 50% of the cases are being sectioned. So 500 ml through the vaginal route, vaginal delivery, and 1000 ml through this thing section is normal, but in a case of antepartum hemorrhage, so 50 to 100 ml, 1000 ml without any signs of clinical shock, we take it as major hemorrhage. And if it exceeds more than 1000 ml, of course, there will be definitely fetal morbidity and mortality too. So the massive hemorrhage will be more than 1000 ml with the signs of clinical shock. Most of the time they go into covalent uterus too, especially in the concealed variety, where we really underestimate the blood loss, because the bleeding is going on inside, and there will be sweeping and through the muscles, and they go into covalent uterus. Very difficult to manage them in the vaginal route. Then coming to the risk factors, when I went through the literature, the recurrent abortion, 4% of the cases, if there was a previous abruption, there will be 4% of the patients will have recurrent abruption again. And very interesting fact and very horrifying factor was, if there are 2 previous abruption, the chance of abruption goes up to 25%. So it is very, very high percentage. Of course, according to the textbook, the preeclampsia, IUGR, non-vertex presentations, so many multicentric trials, Cochrane reviews, everybody says all these are the risk factors for abruption placenta, hydramnios, advanced maternal age, multiparity, and low BMI too. So especially preeclampsia is the most culprit, and incidental hemorrhage, accidental hemorrhage also occurs a majority of the times. Not always there should be a cause. So these also should be taken care of. Nowadays, the ART pregnancies are going on, intrauterine infections, then PROM with chorioamnionitis, then abdominal trauma, whether it's an accidental or domestic violence, still plays a major role in case of abruption. Smoking and drug misuse is also increasing nowadays in the youngsters, where they become young girls who become pregnant. They also are very much prone for abruption placenta. Then another interesting fact which I found when in the literature was threatened miscarriage. This we all know from our my post-graduation time 25 years back ago. Whenever there's a threatened miscarriage in the first trimester, subchorionic bleed, that might go into retroplacental hematoma in the second trimester, and very early preterm births, IUGR with an abruption is increased up to 1.4%. Then nowadays, everybody is speaking about thrombophilias. Of course, this maternal thrombophilias is also associated with placental abruption because of the decreased vascularity. And so that also is a culprit which we need to keep in mind in the present day scenario. So because of these risk factors, we have to, and this is a sudden onset abruption, accidental hemorrhage. So we need to predict how often it might come and how exactly we can prevent it. But unfortunately, prediction of abruption is unexpected obstetric emergency. It's usually sudden and no predictable by known antenatal risk factors. And very interesting fact was 70% of placental abruptions occurring in low-risk pregnancies. I was very, very annoyed when I saw this low-risk pregnancy, 70% of the cases. But we need to agree to that because some statistics show that low-risk pregnancies is also very risky in relation to abruption. And we need to go for a multidisciplinary team. So coming to prevention, of course, there are studies done, folic acid and multivitamins during pregnancy, throughout pregnancy. We do start folic acid preconceptionally to prevent neural tube defects. And we do continue folic acid throughout pregnancy to prevent anemia, megaloblastic anemia, and also it has a proven role in prevention of abruption. So adjusted OR ratios were there, and definitely it was a proven to reduce abruption. Now recently, because of the thrombophilias, the subsequent pregnancy also had a fever placental vascular complication. Placental vascular complications like abruption, eclampsia, low birth weight are also reduced with enoxaparin. This is the recent studies have shown and approved. Then because we can't predict and prevent so much, we need to keep in mind the maternal and fetal complications. Of course, the maternal complication will be anemia. See, with a lot of retroplacental, you see in this picture, we do see so many cases like that. Placenta comes out with an equal amount of placental and more weight of the blood clots are coming out in the retroplacental route. So anemia, of course, infection, maternal shock are no wonder we need to keep all the blood and blood products ready. Then they're suddenly going to renal tubular necrosis because of the underestimation of the blood loss, because of the concealed variety of abruption. Then consumptive coagulopathy and postpartum hemorrhage also are possibility, definitely, because more than 50% as placenta is separated, there will be intrauterine death. Whenever there is a concealed hemorrhage with IUD, more chances of consumptive coagulopathy. So, of course, with all this, they have a prolonged hospital stay, psychological problems will be there, and complications related to blood transfusion. Recently, we had a blood transfusion reaction trolley. It took a hell of a time for us to get her out of the ICU. So we need to keep these things also in mind. Coming to the fetal complications, of course, nowadays, one or none babies they're planning. And that one baby should be very healthy and hale and all. So these people, they have fetal hypoxia, small for gestational age, UGR babies, prematurity, whether it's iatrogenic or spontaneous. Iatrogenic, of course, whenever there is a mild degree of abruption and there is a revealed type of hemorrhage, and fetal heart is there and distress, we need to deliver the baby as and when possible. So they will be definitely prematurity, and iatrogenic preterm labors are also very common. And finally, at the end of the day, we might land up with a fetal death, which is untoward effect. And nobody wants a fetal death for our antenatal women. And sometimes it's very, very difficult to explain to them. They will ask regularly, I'm coming to you, why, madam, suddenly this death has happened? We cannot tell it's an accidental hemorrhage. They will not accept, and we will have a $1 million question, why exactly it has happened? Because 70% of the cases are without any risk factor. Now coming to the management, of course, it is a multidisciplinary team. We need an obstetrician with immediate access to the laboratory. Then operation theater, neonatologist, anesthetist, everything should be there. And this should better to treat in a tertiary care center. Should provide initial clinical assessment immediately as soon as the patient comes. So there comes the point of triaging. So clinical assessment for triaging for urgent intervention to manage maternal or fetal compromise is necessary or not, or it's just a bleeding which has happened for a moment, and then still abruption we cannot ignore, whether it is a little bleed or a bigger bleed, doesn't matter. Massive hemorrhage, obviously we'll take care. The minor hemorrhage also equally important. So the process of triaging includes the history, the pain, with a sudden onset pain, with a stony hard uterus, extent of vaginal bleeding. Sometimes we will definitely underestimate because of the internal bleed, retroplacental hematoma. Then the cardiovascular condition, of course, there will be tachycardia, hypotension, and assessment of the fetal well-being. By the time they come to here and more than 50% placenta is separated, baby is going to die. So these things should be triaged and then decide whether it's what type of treatment I need to give for that patient. So investigations are simultaneously to be done to assess the extent and physiological consequences of APH. Maternal investigations will definitely depend on amount of bleeding. So, of course, one point on anti-D and RS negative women, we need to do quantify the fetal-maternal hemorrhage and then decide and give anti-D dosage also. Then the ultrasound plays a good role because everybody is having an ultrasound machine in our labor room itself. We can diagnose placenta previa by ultrasound, but we cannot exclude abruption all the time. So it has limited sensitivity in the identification of retroplacental hemorrhage. Fresh bleeding is difficult. If there are clots, organized clots, it is easy to identify and then treat as and when it is required. So placental abruption is always a clinical diagnosis, and little value ultrasound has got. But definitely we can rely on ultrasound to rule out placenta previa because both will go hand in hand. Sometimes you'll be confused whether it's previa or an abruption. So there is no sensitive as such a reliable diagnostic test for abruption. Then coming to the fetal condition, once the mother is stable and resuscitation is done, only we go for CTG. Of course, we need to look for the fetal heart present or not because that itself will decide whether we need to deliver in time or which mode of delivery, immediate or we need some time, we have some time, or mode of delivery, vaginal or cesarean section. Definitely, we'll have an idea about it. So fetal heart pulsation, sometimes we have to take care of ultrasound because at times external auscultation like CTG might not work. So directly just put a scanning and see whether the fetal heart is beating or not. So this is very important related to fetal heart rate. Then I always had a doubt whether there is any role of corticosteroids as soon as the mother comes. Of course, 24 to in between 24 and 34 weeks, we can give a corticosteroid. And because we will definitely anticipate preterm birth, but in a case of abruption, whether I can wait or not is $1 million question. If there is a time to wait and then only retroplacental hematoma a little bit and the bleeding stopped and she is with us under continuous vigilance, maybe there is a chance of corticosteroid therapy. Then tocolytics. Again, this is also $1 million question. There is no role of tocolytics as far as senior obstetricians are concerned. I think everybody will agree with me. But if there is an APH, hemodynamically unstable, evidence of fetal compromise, there is no role at all, tocolytics. If at all you need to give tocolytics and if you're deciding to give corticosteroids, for that 48 hours, I think maybe the decision is individualized depending on the patient in front of us. So that things we can plan. And the tocolysis also, again, whether it is going to cause tachycardia, I'm not going to give it. So the drug, tocolytic drug also will be decided by that particular obstetrician on charge. Then coming to the antenatal care, cervical ectropy on antenatal care not altered at all. In a case of abruption, an unexplained APH, obviously, then and there itself we need admission and then decide what to do next. And definitely, whenever there is an abruption, whatever mild hemorrhage or a massive hemorrhage, it is high risk. And the antenatal care should be consultant-led. However, the consultant wants to follow the patient, that should be done. And of course, serial ultrasound for fetal growth should be performed. Coming to the mode of delivery, all of us know if there is immediate abruption and the baby is there and fetal distress is there and the fetal lung maturity is attained, there is no more doubt and enough of NICU facilities, we can definitely deliver them by cesarean section. But if the fetal death is occurred, then vaginal birth is the mode of delivery for most women. So fetus is compromised, no more decision making. So concurrently, we have to resuscitate the mother and also consider cesarean section. Here, I just want to share my experience. We had an IUD and was a covalent uterus. We were waiting within 2 hours. The patient has gone into renal shutdown. Within no time, 2 hours, we were doing all resuscitation, given the blood products. And I just want to tell there is no hard and fast rule like from which time to which time the patient is going to deteriorate or how long I need to wait when I'm going for vaginal delivery. That really depends on the patient's condition at that moment. So our decision in that moment is final. There is no like I need to wait for 4 hours, 6 hours, 8 hours, nothing like minimum assessment.
Vijayashri ma'am, may I interrupt you for a minute?
Yes, ma'am.
Requesting all the faculty, please share the link that I have shared right now in the group with your groups because the initial link that was given is not working. So I have shared a link right now. Please take half a second and share it in all your groups and then we can proceed with the program. Otherwise, people will not be able to watch. Sorry for the interruption, ma'am.
No problem, no problem.
Requesting everyone, I've shared it in the group. Please share it in all your society groups. Ma'am, please go ahead now.
Okay, ma'am. Coming to the mode of delivery, of course, when you are going for a vaginal delivery, I already told this is my own experience I was telling, and most of us would have experienced similarly, ma'am. Optimum timing of delivery of unexplained APH, which is not associated with maternal fetal compromise, not is still established. So that particular patient who has had little bleeding might go into massive hemorrhage within no time. Or a person which is having 1/4 of the placenta which are separated still can go on for 2, 3, 4 weeks alone. So these are the things which we have to keep in mind, and patient should be admitted, but individualization of the case should be done. Of course, the senior obstetrician's decision will be final because they would be very learnt and experienced. Then when coming to the vaginal route, I would like to give misoprostol, of course. We do have 3 different reasons, whatever we give, dinoprostone or a Foley's catheter or misoprostol. Among them, I think as delivery interval time should be as minimized as possible in such cases. So I would like to give misoprostol. I think everybody will agree with me. Depending on the doses, every 4th hourly, 3rd hour, I can repeat so that she will expel as soon as possible. Coming to the fetal monitoring, when in labor and active vaginal bleeding, they require a continuous electronic fetal monitoring, no doubt about it. But if the patient is already in preterm labor, major APH, recurrent APH, clinical suspicion of abruption, I think we need to go for continuous monitoring. And if there is any abnormality, immediate termination is indicated. So one episode of minor APH, no concerns regarding maternal and fetal well-being. Maybe intermittent auscultation is appropriate. I remember my PG days, we always had that fetoscope with us. Whether it's abruption, placenta previa or any other thing, we always used to carry that fetoscope and we will be going on listening to the intermittent auscultation. Now, all our PGs and students are luxurious. They have an NST in their labor room. So obviously they can just tie that NST and go through these things. If there is a minor APH with evidence of placental insufficiency, definitely there will be IUG or oligohydramnios. We need to go for continuous CTG. So anesthesia, we all know it is definitely general anesthesia, very, very rare and less role of regional anesthesia. And maternal resuscitation will be easy if I give a general anesthesia. And we need the help of anesthetist, should be involved in intrapartum care of the woman also. Because by then, a lot of hemorrhage would have happened and she would have gone into shock, maybe sometimes imminent renal shutdown. So they will definitely help us. And finally, prevention of PPH, active management of third stage should be done in all the cases, no doubt about it. And the best thing is ergometry and oxytocin in the absence of hypertension and contraindications. Of course, our misoprostol also will work equally good. So when, as and when it is required, better to go for active management for everybody. Universally, active management of third stage of labor is mandatory. RH incompatibility, I already told you, we need to give anti-D. And if at all feto-maternal bleed is there, then we have to go for increasing the dose. Anybody who is having internal bleed more than 20 weeks, at least 500 units of anti-D should be given. And additionally, depending on the Klein-Hor-Bethke test and increase the dose also can be decided. And then comes the blood and blood products. Decreased coagulopathy and increased survival was reported when we are given fresh frozen plasma and pack cells. 1:1 or 1:1/4. That means for every 3 packets, 2 packets of FFP. And we did had a lot of experience on this. We always keep FFPs ready in our refrigerator blood bank, and they do give us as and when it is necessary. And clotting studies, platelets also should be done then and there itself. So the laboratory technician also plays an important role. And whenever there is a massive blood loss, especially with an IUD, definitely there is chance of going into DIC. So that should be kept in our mind. Up to 4 units of FFP and 10 units of cryoprecipitate may be given while awaiting the results so that the bleeding will get controlled. Lastly, one word about neonatal unit. Of course, whenever there is a massive APH, fetal anemia and fetal compromise are definitely expected. So senior pediatrician, neonatologist with an intensive care unit should be there. And clinical judgment is used in a case of minor APH. So while continuing the hemorrhage, it will be appropriate to request pediatrician support also, especially regarding the timing of delivery. If at all very preterm baby is going on and we need to deliver, we don't have any other choice, then better to keep a surfactant ready and also the pediatrician, neonatologist informed about such condition. And finally, take home message, regardless of the gestation, mother's life is very, very important. We all deal with 2 lives. Okay, the mother, baby, at times 3 lives. Obstetrician also, we are also very much, we have to take care of our life also nowadays. So whenever it comes, both the mother and baby are equally important for us. But when it comes to mother or baby, mother is more important. So obviously, regardless of the gestation, we need to take care of the mother's life. She should be definitely resuscitated, stabilized before decision of delivering the baby is taken. And pediatrician and neonatologist should be informed because sometimes extreme preterm birth is also very likely. So lastly, to end the session, the postnatal management of pregnancy is very important. Sometimes we need to give thromboprophylaxis. And I just want to tell about debriefing and clinical incident reporting. That's what we are doing in our Mamata hospital also, because these are the cases where they go into near miss. They go up to that ICU and it takes a lot of time to get them back. So we do definitely take care of the case, what happened, when it has happened, how it has happened, where it has happened, what else we can do to prevent all these things. We'll definitely take care of these things, especially with the clinical incident reporting, so that we can prevent. We cannot predict prevention also to some extent, but at least some high risk factors we can control so that we can reduce the maternal mortality related to abruption. Thank you so much for giving me this opportunity, ma'am.
Thank you, ma'am. Thank you so much. Requesting the chairpersons to say a few words.
Thank you, ma'am, for such an elaborative and informative session. I have a query, like in massive abruption, like what is the maximum dose of anti-D that can be given and how will you calculate it, ma'am?
300 only, madam. Maximum is 300 only. Whatever internal bleed is there, maximum 300.
But it's written as 500 international units.
That's okay, ma'am. But what happens is that is only more than 20 weeks. We need to give that. But 300 micrograms is ideal, madam. Now, because that is theoretical, which I told you. But actually, what is available is 300 only. What is available is 300 only. But I don't. In my experience, I didn't give anything more than 300.
Okay, ma'am. Thank you for such an interesting and elaborative session.
Thank you, ma'am. Thank you.
Purushottam sir, would you like to say something? Vijayashri ma'am, would you please stop sharing?
Yeah.
That was really great. Thank you.
Ma'am. Thank you so much. Hope I'm in time, madam. I didn't exceed my time.
Yeah, you're very much in time, ma'am.
Okay, ma'am. Is it okay?
Thank you.
Yes.
Thank you so much. So, share screen. So, I would like to introduce the chairpersons of the second session. That is Dr. Swarupa Rani Akula and Dr. Aparna Vatambar. So, Dr. Swarupa Rani ma'am is the medical director of Swarupa Hospitals, Mancherial, founder of the Mancherial Society, and also the present president of Mancherial Society. She was previously the secretary, active Foxian, has undergone TOT for Dhira, RAC. She's an LLB as well, and PG Diploma in Medical Legal Sciences from Symbiosis, Pune. That she's proud to share that first time in history of Dhira training, 4 schools went online at a time, trained 1,500 students. She's conducted many health camps, anemia screening camps, cancer screening camps, and has conducted many CMEs and workshops. Then we have Dr. Aparna Vatambar ma'am. She did her graduation and post-graduation from MGM College, Sevagram, Wardha. FMAS at World Laparoscopy Center, Delhi. She's worked as an assistant in Government Medical College, Mahbubnagar from 2017 to 20. She was secretary for Mahbubnagar from 23 to 24 and presently working as president, Mahbubnagar Society. She is consultant at Anil Surgicare Hospital, Mahbubnagar. Over to you, chairpersons, to introduce our speaker, Dr. Gauri Shri ma'am.
Good evening, everyone. Am I audible, ma'am?
Yes, ma'am.
Yeah, I take immense pleasure in introducing our today's speaker of topic placenta. Today's speaker of the topic placenta previa. Dr. Gaurishri is a brilliant brain from the Karnoor Medical College. She did her certified courses in fetal ultrasonography, ART, and laparoscopy from best of the teaching institutes and experts of the fields. She holds the vast experience of 30 years in the government and private sector and presently serving the people of Nalgonda as assistant professor in Kamineni Institute, Nalgonda. Eager to listen to you, ma'am, on today's topic. Over to you, ma'am. Gaurishri, ma'am.
Thank you very much and good evening, everyone. Associate Professor from the Medical College. I must thank Dr. Patel for giving me the opportunity.
Gauri ma'am. Gauri ma'am. Ma'am, we can't hear you. Madam is logged out. I'll just call and see. Madam has logged out.
Well, meanwhile, Asha ma'am, can I speak some words, few words, till ma'am gets connected? Asha ma'am?
Yes, ma'am. Go ahead. Please go ahead. Yes, Gauri ma'am, what are you saying?
No, meaning by the time we get back to ma'am, I just wanted to thank Dr. MTP Patel sir and the team. I'm Dr. Swarupa from Manchurian. Come here.
Night. Morning or night?
It's night. It will become night in some time.
It's morning.
It's morning? Okay. Pattiga. Takataka dinese nana నాకు కొంచెం. Very happy to see the mothers. They're out here. Equally feeling responsible with the kids while attending the classes. Gaurishri madam.
Am I audible? Am I audible, ma'am?
Just now, ma'am, but still the.
Yes, ma'am, you
Am I
are
audible?
audible.
Yes. Welcome back.
But the presentation is not on the screen, ma'am.
Ma'am, the presentation is on the screen.
You move the slide, that's all.
Yes, yes. Yes, ma'am.
Yes. Meanwhile, we request the other participants to mute themselves so that it will be disturbance free. Thank you.
Gauri ma'am, can you see it now? Dr. Swarupa,
Ma'am.
Would you like to say something about it? I'll move the slides because ma'am is totally frozen. I don't think she will be able to participate.
Oh, in that case, if you run the slides, I can just
I will
go
run
through
the
them.
slides.
Yes, ma'am. So today, because there are two signals with Dr. Gauri Shri ma'am, I'm taking over. Yeah, by definition, we all know that complete or partial covering of the internal os with placenta is known as placenta previa. Incomplete, it completely covers the internal os. Marginal, less than 2 centimeters from internal os. Low lying, when it is more than 2 centimeters away from the internal os. 90% or more than 90% are diagnosed in the second trimester, and but will no longer be present at term. Placental lower edge covering more than 2.5 centimeters is less likely to resolve. And the risks associated are, it can cause APH. It is a major risk factor for PPH during delivery. And it prevents safe vaginal delivery. Most times we opt cesarean section. It increases the risk for placenta accreta syndrome. Can we go have next slide? Next, please. Yeah. It increases the risk for placenta accreta syndrome. It needs blood transfusion. At times, we have to opt for hysterectomy, followed by infertility and admission to ICU, and even death, unfortunately, sometimes. It needs for interprofessional team for management. It is associated with significant maternal and perinatal morbidity and mortality. Objectives of this presentation here are to know the risk factors for placenta previa, the pathophysiology behind it, and management protocols depending upon the GA and clinical presentation and stability of the patient. Importance of
Gestational age. Ma'am, I'm audible now.
Yes.
Excuse me. Ma'am,
Yes.
am I audible?
Yes, ma'am. Gauri Shri, ma'am. Okay, management protocols depend upon gestational age, clinical presentation, and stability of the patient. Importance of interprofessional teams for better outcomes. Important note on placenta accreta syndrome. Okay, age use. The common risk factors associated with the etiology are age more than 35 years and multipara, smoking. The nicotine and CO vasoconstrictors of placental vessels causes the placenta previa and other symptoms. The cocaine use is also associated, which is rise nowadays. Prior history of DNC will cause, and nowadays artificial reproductive techniques are being used in conception. That is also one more reason. Previous cesareans are again a risk factor. Previous placenta previa is also a risk factor. Hysteroscopic surgery and adhesional lysis, etc. are also precipitating factors for this. Next, please. Next slide, please. Pathophysiology. The environment, which is rich in oxygen and collagen, is needed for implantation of a zygote. Trophoblast cells, that is the future placenta and membranes, adheres to decidua basalis, forming normal pregnancy. Prior uterine scars provide rich source of oxygen and collagen, thus favoring implantation in lower uterine segment or uterine myometrium. The concept of migration. Here, low-lying placenta edge within 2 to 3.5 centimeters from internal os. Marginal placenta previa is edge within 2 centimeters of internal os. Nearly 90% of low-lying placenta resolve by third trimester due to placental migration. Placenta itself does not move, but because the growing uterus will shift the position of the fetus, and it grows towards increased blood supply at fundus. Distal portion regresses due to poor blood supply at lower uterine segment. Growth of lower uterine segment increases the distance from cervix. 0.3% to 2% of pregnancies have placenta previa. The incidence is increased with increased rates of C-section. Usually it presents with painless vaginal bleeding during second or third trimester. Bleeding is provoked by intercourse and per vaginal examinations. Per speculum should be a gentle examination which will cause minimal and active bleeding. Once per speculum examination reveals minimal and active bleeding, placenta visualized if cervix is dilated. Mind you, we should not do digital examination. A strict no to digital examination. Even if it is mandatory and it has to be done, it should be very gentle through the pharmacist. Diagnosis. It is diagnosed using ultrasonogram in first and second trimesters. Follow-up is again through ultrasonogram for evidence of persistent placenta previa. And vaginal bleeding, transabdominal scan is recommended. No TVS, please. And no vaginal bleeding, transvaginal scan is superior and safe. Distance of edge of placenta from internal os is measured. Evaluation of placenta accreta syndrome, that spectrum, the placenta accreta adhesion spectrum should be seen and clearly diagnosed with ultrasonogram and documented. Need for MRI to confirm PAS to be considered. Diagnosis using ultrasonogram. TIFA with placental localization for at-risk women is a must. Transabdominal scan, transvaginal scan, transperineal scan can be used. Transvaginal scan is superior and safe provided there is no vaginal bleeding. Placenta should completely cover the internal os to say it is a complete placenta previa. More than 16 weeks gestational age, even at that age, if the placental edge is less than 2 centimeters from internal os, it is low-lying placenta. Low-lying placenta or placenta previa at the TIFA scan has to be documented. TVS should be done to diagnose persistence at 32 weeks. Persistent lower-lying placenta or placenta previa at 32 weeks. And TVS is done at 36 weeks to discuss the plan of delivery. TVS for cervical length, important for management. Decisions to make short cervix at the rate of 34 weeks. Risk of emergency like preterm labor and massive hemorrhage and to be decided for the cesarean section. Ultrasound imaging, the placenta previa and PAS syndrome. Here in the 2D grayscale signs, we have for the loss of the clear zone. There is a loss or irregularity of the hypoechoic plane in the myometrium underneath the placental bed. The clear zone is not there. Abnormal placental lacunae. The presence of numerous lacunae, including some that are large and irregular. Finberg grade 3. Turbulent flow visible in grayscale imaging. Bladder wall interruption. There is loss of interruption of the bright bladder wall, the hyperechoic band or line between the uterine serosa and the bladder lumen. There is myometrial thinning overlaying the placenta to less than 1 millimeters or undetectable. Placental bulge. There is a deviation of the uterine serosa away from the expected caused by an abnormal bulge of placental tissue into a neighboring organ, typically the bladder. The uterine serosa appears intact, but the outline shape is distorted. There can be a focal exophytic mass with the placental tissue seen breaking through the uterine serosa and extending beyond it, most often seen inside a filled urinary bladder. Next slide, please. Second, the 2D color Doppler signs, utrovesical hypervascularity, striking amount of colored Doppler signal seen between the myometrium and the posterior wall of the bladder. This sign probably indicates numerous closely packed tortuous vessels in that region, demonstrating multidirectional flow and aliasing artifact. Subplacental hypervascularity, striking amount of color Doppler signal seen in the placental bed. This sign probably indicates numerous closely packed tortuous vessels in that region, demonstrating multidirectional flow and aliasing artifact. Bridging vessels, vessels appearing to extend from the placenta across the myometrium and beyond the serosa into the bladder or other organs, often running perpendicular to the myometrium. Placental lacunae feeder vessels, vessels with high velocity blood flow leading from the myometrium into the placental lacunae, causing turbulence upon entry. 3D color Doppler signs. 1 second, ma. Yeah, intraplacental hypervascularity, that is a using power Doppler, complex irregular arrangement of numerous placental vessels exhibiting tortuous courses and varying calibers. Next slide, please. The placenta accreta, that is the attachment of placenta beyond normal boundary of myometrium, that is Nitabix fibrinoid layer. Placenta increta is invasion of placenta into myometrium. Placenta percreta is perforation into serosa or surrounding organs. High index of suspicion is the only reason where we can diagnose. And this placenta accreta syndrome has major risk factors wherein prior history of PAS, prior LSCS or other uterine surgery, repeated endometrial curettage, more numbers of previous cesarean sections, previous LSCS with anterior low-lying placenta or placenta previa. 80% of PAs have placenta previa. The diagnosis is again by ultrasound imaging of the PAS syndrome, the spectrum, the PAS spectrum in a specialized unit with imaging expertise done especially at the Tifa scan center, that is second trimester. And MRI has no extra benefit over well-performed ultrasonogram by an expert. MRI is only complementary to ultrasonogram. It gives us the depth of invasion, lateral extension, especially with the posterior placentation. Ultrasonogram showing parametrial invasion, bladder invasion, etc. Management of PAS leads to massive hemorrhage, damage to lower urinary tract, need for blood transfusion, and risk of hysterectomy. So, integrated team approach is needed before planning the delivery. Adult ICU is needed, NICU team is needed. Team should be able to deal with complex pelvic surgeries, wherein if percreta is there, we have to do bladder excision and other things. So, planned delivery at 35 to 36 weeks, plan cesarean hysterectomy when needed. Regional anesthesia need to be converted to general anesthesia if needed. To leave placenta in situ to avoid massive hemorrhage when delivering the placenta. Management of placenta previa depends on whether bleeding is absent, recurrent, or massive. Gestational age, preferably less than 34 weeks or more than 34 weeks. It gives us, like, if it is less than 34 weeks, the complications of neonate is more than 34 weeks, at least little maturity of the baby is there. Facility, there should be a maternity unit with on-site blood transfusion services and access to critical care unit. Rapid infusions and fluid warming devices should be immediately available because hypothermia destroys the clotting mechanism, adding to the catastrophe. Cell salvage for massive blood loss, women who decline transfusion. Women with atypical antibodies are particularly at high risk group regarding blood transfusion, such as KS, anti-C, etc. They're really a nightmare. Intraoperative cell salvage, safe and effective tool in the management of significant intraoperative blood loss at C-section. It is most cost-effective for women at risk for PPH, beneficial for those with more than 1000 ml of blood loss. No serious adverse effects reported so far in pregnant women. Avoids risk of donor blood transfusion. Management of antenatal cases, all necessary routine. 1 second. Antenatal care is required. Special emphasis on anemia and improving the hemoglobin status forms the baseline. More care with Rh negative mother. Bleeding, clotting abnormalities, including thrombocytopenia, have to be ruled out. Other associated risk factors like heart disease, PIH, GDM, etc. should be ruled out or taken care of. Next slide, please. In the antenatal period, we should advise bed rest with reduced activity, though it says no clear benefit, but maybe it will not trigger the bleeding in between. Avoidance of intercourse is very important. Assessment of risk of thromboembolism in case women needs bed rest, especially with the obese women and other syndromes. Hospitalization when bleeding occurs. The patient should report immediately once the bleeding starts. Next slide, please. In the antepartum period, inpatient versus outpatient management depends upon whether the stability of the patient, number of bleeding episodes, proximity to the hospital. If the patient stays far away and cannot reach in time, better to hospitalize the patient for observation, and availability of transport, and the lab results, and also the acceptance of receiving donor blood and blood products, because some patients, even due to their religious reasons, they don't accept the blood products from others. And patient compliance, that forms a major line of treatment, because if the patient is non-compliant, she may land in severe hemorrhage. And management at home, second and third trimester, if the patient doesn't have, if the patient has minimal bleeding, can be managed only in case of bleeding, spotting, and pain or uterine contractions. The patient should report to the hospital. There should be always an attendant with the patient at home, and there should be easy access to the hospital from the home. Then only the patient can be managed at home. And management at admission, investigations, the routine like her all blood investigations, the urine LFT, RFT coagulation profile with fibrinogen level, ECG and electrolyte should be done. Intraoperative ultrasonogram has to be done to see the extent of placenta. And elective delivery after 36-37 weeks, elective C-section is ideal. Emergency C-section earlier if associated with complications. Patient with excessive and continuous bleeding during cesarean section, mandatory regardless of GA. And known history of placenta previa, admission at 36 weeks, magnesium sulfate for fetal neuroprotection, and steroids for lung maturity in case we are planning a delivery at 36 weeks. Emergency management, again, by monitoring the mother, the vitals if they are stable, always have 2 large bore IV lines, and complete blood picture should be taken. Blood group and RH typing should be noted very well. And 2 to 4 units of blood should be cross-matched and kept ready before taking up for any surgery or delivery. Uterine artery catheters placed before the procedure by interventional radiologist. Monitoring the fetus, electronic fetal monitoring is preferred. Management and delivery preparation. First, the patient has to be counseled with regard to all the complications, and consent has to be taken, especially in case she lands up with severe hemorrhage, needs a hysterectomy. So she should be counseled to the extent of hysterectomy, and the poor fetal prognosis in case it is a preterm condition. And the communication with other teams is very important, especially the anesthesia team, the pediatrician, then the surgeon and the blood units, everything. Like the teamwork works wonder here. Counseling, the patient and the attendants have to be involved. Always discuss regarding the possible complications. Plan for a cesarean hysterectomy. Multiple blood transfusions and associated complications should be explained to the patient. A blood reaction, and also coagulation, coagulopathies in case there are more blood transfusions and need for the blood products like the components, FFP and others should be counseled beforehand. And about leaving the placenta behind and associated risk and time implications. At times when there is a percreta, sometimes we leave the placenta behind and then close the uterus in case there is no active bleeding. And follow-up is very important because we have to watch how it is autolyzing, any signs of infection, and we need frequent ultrasonogram to monitor all that. And the extra costs involved should be explained to the patient and counsel. Warning about serious morbidity and at times mortality has to be clearly explained to the patient's attendants and the patient. recurrence of placenta previa, low-lying placenta, and placenta accreta spectrum has to be discussed with the patient and their attendants. Next, consent is a very, very important thing. Nowadays, in the case of all medical legal litigations sprouting up, irrespective of how authentically that the doctor is trying for the patient's well-being, so we should be very careful while taking the consent. It is very important. It should be verbal, written, and video counseling is mandatory. Though the written consent should be in the writing of the patient or patient's relative, preferably in their own language, with duly signed, date and time to be mentioned, prematurity and related complications, including neonatal mortality in very preterm thing has also to be discussed. Hysterectomy and related infertility in case the woman is primigravida has to be clearly explained. Consent for uterine artery embolization at higher centers. And transfusion of blood and blood products. Also, the consent for transfusion of blood and blood products is also very important. Customized high-risk consent should be taken. Need for extra costs, need for intervention by other consultants has also to be explained, and the consent for the same has to be documented. Communication is the key here. The interprofessional team approach is essential. Gynecologist with reasonable experience, a urologist and general surgeon in cases of placenta percreta, and then anesthesiologist who begin with when may start with a local anesthesia, but may be converted there may be a need for conversion to general anesthesia. The anesthesiologist to be competent enough, and then committed nursing staff should be there. Pediatrician should be well informed priorly. Blood bank facility has to be double checked with the required blood available at the blood banks, and interventional radiologists whenever they are available. Next slide, please. Facilities. A tertiary care center where all necessary facilities available is an ideal place to deliver such patients. Plan of delivery. If it is between 34 to 36 weeks, if the patient presents with vaginal bleeding and other associated risk factors for preterm labor have to be explained, and then steroid coverage may help. 36 to 37 weeks, uncomplicated placenta previa can be delivered easily. Cesarean section, expectations to the surgeon. The surgeon should have adequate exposure in such cases, operating such cases. If there is no bleeding or excessive bleeding, it is the ideal case. Additional styptic drugs which can control the bleeding should be kept ready, like prophylactic tranexamic acid, IV will help. Additional procedures to control hemorrhage, like stepwise revascularization, where you can have this uterine artery bilaterally can be ligated to decrease the blood loss. Conservative management of placenta. The placenta can be left in situ, provided there is no active bleeding. Experienced surgeon should do or should be available whenever required. So to keep a surgeon at hand and informed, and then you can proceed. And emergency management, the regional is better than general. Decreased operative blood loss, because in spinal anesthesia, due to hypotension, there is no much blood loss, but decreased need for blood transfusion, and inhaled anesthetics cause uterine relaxation and more blood loss. So spinal epidural combination, once again, spinal epidural combination is recommended for non-urgent cases. Conversion to GA on emergency is required. Next, please. The procedure in cesarean section, it should be a vertical skin incision, intraoperative ultrasonogram for placental location, and optimum placement of uterine incision is required. High vertical uterine incision in case of placenta completely in lower uterine segment, and lower uterine segment underdeveloped, like in cases of preterm elective LSCS, it can be thick and underdeveloped, or in a case of transverse line. If placenta is incised, immediate cord clamping to avoid fetal blood loss is recommended. Routine closure if no bleeding. Cause of bleeding after placental detachment, decreased contractility of lower uterine segment need for additional procedures. Cesarean section at times needs additional techniques. In case of PPH, we have to do a bimanual massage or aortic compression, clamping in best resource settings. Uterotonic should be given meticulously. And then one second. Previous slide, please. Intrauterine tamponade with balloon or gauze, stepwise devascularization, and B-Lynch sutures or transverse B-Lynch brace sutures should be given. Then Hackathol suture, multiple transverse uterine sutures, Cho sutures, square sutures, and uterine or internal iliac artery ligation or embolization, where the setup permits, partial myometrial resection, hysterectomy with or without placenta in situ. Have to be recommended. Next slide, please. Intra and post-operative care, close monitoring of volume status, urinary output, ongoing blood loss has to be monitored, use of hemorrhage checklists, attention to blood loss, hemoglobin, electrolytes, blood gas, coagulation parameters have to be monitored, use of Paxils, FFP platelets depending on name, autologous cell saver technology, antifibrinolytic therapy, prophylactic tranexamic acid after cord clamping, recombinant activated factor 7 in severe refractory hemorrhage. Role of interventional radiology, more studies are required. Prior catheterization when facilities available, if patient consents or if patient declines blood transfusion is a good thing.
So Rupa ma'am, if you could just, finish it fast instead of reading all of it because we are running quite late.
Okay, madam. So undiagnosed or unsuspected PS spectrum, the C-section should be delayed until appropriate. If no facility is available, immediately close the abdomen and shift to higher center. If it is detected after the baby delivery, placenta left in situ and emergency hysterectomy is performed. Next, please. PS is associated with massive hemorrhage. You should leave the placenta behind and go for emergency cesarean hysterectomy. If there is a high index of suspicion of PS, then cesarean hysterectomy without manipulating the placenta. Next, please. Conservative management. If patient desires fertility, maybe we'll have to preserve the uterus, but with the recurrence rates and all those things, and if the patient is stable, we can still try conservative management. But if it is heavy, massive hemorrhage is there, then we have no other choice left. And role of methotrexate in cases of where placenta is left in situ, we can give methotrexate for the effect to be taken place. Next one. In low-lying placentas, which are more than 2 centimeters away, we can try a vaginal delivery, but the risk of PPH and emergency C-section rate is high. Next, please. Next. Differential diagnosis between the subchorionic hematoma in the second trimester, ectopic pregnancy, molar pregnancy, then abruption and vasa previa of the DD. Next slide, please. So prognosis in neonatal, there is 3 to 4-fold increase in the neonatal mortality or morbidity because of the prematurity. So increased risk of preterm birth and low birth weights, RDS, etc. Next. Prognosis in 90% of placenta previa cases resolved through delivery, but poorer prognosis in cases where it is previous LSCS with anterior placenta previa due to PAS. So blood transfusion risk is there, the associated risks and injury to nearby organs and cesarean hysterectomy. Next, please. So complications for the mother, PIH, blood transfusion related complications, hysterectomy, DIC, urologic abnormality, etc. Sheehan syndrome and neonate preterm birth, LBW and Apgar scores, low Apgar scores. Next, please. Oh, this is the ultrasonogram diagnosis and follow-up of the flow chart. Next, please. Documentation already we have discussed. It is very, very important for to protect ourselves. Conclusions. Placenta previa or placenta accreta spectrum is associated with significant maternal and neonatal morbidity and mortality. The assessment of risk factors gives a clue. Anticipation through second trimester can help, and good antenatal care with plan of delivery according to the patient categories improves the outcome. Multidisciplinary approach is the key. Counseling, consent, and communication is very, very, very important. Thank you. Thank you very much for giving this opportunity and a patient hearing. Thank you for the patient listening. Ma'am.
Thank you, ma'am.
Yeah, ma'am.
Gaurishri ma'am, if you can hear us, would you like to say something? It's your presentation, and thank you, Dr. Swarupa, for taking over and, saving the day. And Aparna ma'am, if you wish to say something, please. You're muted, ma'am. Aparna ma'am, you're muted.
Sorry. Indeed, it was a very thorough presentation, madam. Gaurishri madam, we can see your efforts. And well done, Dr. Swarupa, for managing the condition on the 11th hour. And loads of thanks to the organizers, MC Patel sir and Dr. Asha madam, for giving me the opportunity to be part of this webinar. Thank you, ma'am.
Thank you so much. Thank you, Swarupa ma'am, and thank you, Dr. Aparna, for saving the day, because it's going online. It's very difficult to manage.
I know.
So, thank you so much. And I don't see very many panelists, but I'm requesting Shirisha ma'am, whenever you don't see somebody, please take over.
Sure.
Thank you.
And requesting everyone who's present here, if the panelist is not present, anyone can take over and ask that question. Okay?
Sure, ma'am. Thank you.
Thank you, Swarupa madam.
My pleasure, sir. Anytime.
Yes.
Only
We
thing is I
have-
was not prepared for that.
No, but
Ma'am,
Yes,
nobody
yes.
is prepared for placenta previa.
I know. Yeah, true.
even though
Very
it
true.
was
Very true.
it was at par, even though.
Thank you, sir.
So, our expert today is MC Patel, sir, and I am the one who's going to moderate your questions. So, I would now formally like to introduce sir. We all know sir for so many years. He's a consultant obstetrician gynecologist and medical legal counselor. He was the VP Foxy 2018, organizing secretary of AICOG 2017. Also the chairperson Ethics and Medical Legal Committee Foxy 2011 to 13. Honorary secretary SOGO 22 to 24, organizing chairperson MMCon. There's a whole list. But more than anything else, he is a very well-loved medical legal expert who is available 24/7 for every Foxian, for any medical legal help. And whenever you are in a soup, you can call him anytime. If you consult him before, you can be saved from that soup. He is consistent, approachable, and though he appears very simple, but in a court, he can be really strong. And it's always better to have him on your side rather than on the opposite. So welcome, sir. And that's me. I've been introduced, and I would like to share this once more because I made a mistake. So here's a request from sir.
शुभं करोतु कल्याणम् आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ आगे है बढ़ते जाना.
Before we take the program forward, I request all of you to please vote for me for Food, Drug and Medical Surgical Equipment Committee Foxy. Voting will be between 16th to 25th August. Thank you so much for the nomination. Now we have our moderators and our expert panelists whom I will be introducing as the questions come along. And before we actually call the panelists to introduce the topic, I would like to ask, sir, so what was the need of the MTP Act and why was the first act made? What were the indications of the initial act?
This MTP Act was enacted in 1971, and before that, any abortion services to terminate pregnancy was considered a crime, and both were considered guilty, patient and doctor who was giving services. So in this era, due to this strict restriction to have abortion services from expert hand, they used to go to quacks, and there was so many morbidity and mortality. So considering this, government formed a committee, Santilal Shah Commission, in 1966, and that commission came up with this MTP Act proposal in 1971. It was enacted, and rules and regulations were formed in 1975, and then after this act has come in existence. So main motto of this act was to make registered medical practitioner free of purview of Indian Penal Code if they go for abortion services as per provision of MTP Act 1971. And MTP services should be available to each needy and eligible patient in government hospital totally free of cost, and it should be kept confidential. So with these three aims, this act was enacted.
Thank you, sir. Now, I would invite Dr. Rehana Begum, ma'am, who is the ex-secretary of IMA Khammam and organizing committee member TCOP 2016 Khammam, to take this question. Dr. Rehana, ma'am, are you there?
Yes, ma'am. Yes, ma'am.
Yes, welcome, madam.
Yes, ma'am. Welcome.
Thank you, MC Patel, sir, and Asha Jain, ma'am, for giving this opportunity. And my first question is, already we are running late. What were the important provisions of the Act? Was there any punishment included in the Act?
So as far as provision of this Act is concerned, in this Act, it is very specifically mentioned where MTP can be done and who can perform MTP. And if place is not registered and person has done MTP or person is unqualified and has done MTP, there is a provision of punishment of 2 years of imprisonment, and it may extend it up to 7 years. And if there is discrepancy in record, then there is a provision of fine of rupees 1,000. So this is the punishment part. So as far as provision of place is concerned, any government hospital or government aided hospital or any clinic registered by district level committee or government center is registered for termination of pregnancy. As far as person is concerned, any allopathic graduate who is registered in medical council and now in your version, National Medical Commission with requisite experience can terminate pregnancy, and experience varies as per gestational age. As far as postgraduate degree, diploma, DNB in OBGYN concerned, they are eligible to terminate pregnancy at any given gestational age as per provision of MTP Act.
Thank you, sir.
Asha madam, you are muted. Please unmute.
Yes, sir, I have unmuted.
Okay.
First,
So
I
we
would
have
like to.
Shailja ma'am. Welcome, ma'am. Director and Clinical Head Department of Gynae at Shamala Hospitals, Khammam. Welcome, ma'am.
Yes, ma'am. First, I would like to. Am I audible, ma'am?
Yes,
ma'am. You are audible.
Yes.
Requesting everyone who's not speaking, keep yourself mute, please. There's a lot of disturbance.
I would like
Please
to
mute
congratulate
yourselves.
sir for this 195 webinar session. Really, you're great. And thank you for giving me this permission and giving this opportunity and making me part of this program. Thank you, sir. First, I would like to ask, how effective was the initial act in its purpose of decreasing unsafe abortion? And how many times was it amended and why? What is the latest amendment? That is 2022, September. And how does it benefit the women and doctors? And I would also like to know about that board, medical board. Who will form that board and who all are included in that?
So as far as this, how effective was the initial act? Just I mentioned prior also, this act was enacted to take care of patients who are eligible to go for termination of pregnancy, and they should not be ended into hand of quacks. It was the main purpose of this act, and to make registered medical practitioner free of purview of Indian Penal Code. Because just I mentioned prior also, before this act, any termination of pregnancy were considered crime under Indian Penal Code. And even today also, under Indian Penal Code 1860, section 312 to 316, to terminate pregnancy is crime even today. But there is provision given in MTP Act 1971 that notwithstanding anything contained in Indian Penal Code or any law time being in force, registered medical practitioner will not be considered guilty if he has terminated pregnancy as per provision of MTP Act 1971. So not to end up into purview of Indian Penal Code, it is very much necessary to terminate pregnancy as per provision of MTP Act 1971. As far as amendment is concerned, first amendment came in 2003. This act was originally enacted in 71. Rules and regulations were formed in 75, and first amendment came in 2003. And in that very amendment, power were delegated to district level committee. Previously, if at all anybody wants to register her place as a MTP center, then he had to apply to the government only. But after this amendment in 2003, district level committee is formed, and one can apply to district level committee also as far as registration is concerned. And second amendment came in 2020, and rules were amended in 2021. And with this amendment, there are so many good amendments in favor of patient as well as in favor of doctor also. So if we go one by one, previously termination of pregnancy was allowed up to 20 weeks of pregnancy and up to 12 weeks with opinion of one registered medical practitioner, and after 12 and less than 20 with opinion of 2 registered medical practitioners. But with this amendment in 2021, now pregnancy up to 20 weeks can be terminated by opinion from 1 registered medical practitioner only. More than 20 and less than 24 under special categories with opinion of 2 registered medical practitioner, pregnancy can be terminated. And beyond 24 weeks of pregnancy, with opinion of medical board, one can terminate pregnancy. But as far as medical boards are concerned, so each district should have medical board is the requisite under this amendment of MTP Act. So there are so many districts in that very district boards are already formed. If it is not formed, that we should take initiative on level of society to approach respective authority who is looking after MTP Act, and we have to request to form committee, because it is prerogative of government only. 1 gynecologist, 1 pediatrician, and 1 sonologist will be there in that very board, and government may invite 2-3 more people also from private sector also. So this is board. And as far as power conferred to board is concerned, board can give opinion in case of fetal congenital anomaly which are incompatible with life of fetus. So if pregnancy has advanced 24 weeks and fetus has congenital anomaly incompatible with life, then medical board can opine to terminate pregnancy at any given gestational age. And 2 good amendments came with this related to medical board only. Medical board is under obligation to opine within 3 days. Previously, what happened? If pregnancy was more than 20 weeks, usually patient approached to Honorable High Court seeking writ petition for termination of pregnancy. And Honorable Court were referring that very case to medical board to opine whether pregnancy should be terminated or not. But there was no time limit fixed. In one of the cases, it was happened that opinion was asked at the 24 weeks of pregnancy, and when opinion came, it was 36 weeks of pregnancy. So not to end up into this type of problem, with this amendment, medical board is under obligation to opine within 3 days. Once any application is done to medical board to opine whether pregnancy can be terminated, then medical board will opine within 3 days. And one good amendment came, once there is opinion from medical board that pregnancy can be terminated, then that very pregnancy should be terminated within 5 days. So these 2 good amendment came in favor of patient.
Sir?
And one more amendment came as far as failure of contraception is concerned. Previously, it was available to married woman and to her spouse. But now word married woman is replaced by any woman, and word her spouse is replaced by her partner. So irrespective of her marital status, whether she is single, whether she is widow, whether she is separated, so whether she is living in a relation, but if she is major, she can avail these services to terminate pregnancy. In case of minor, there are some another provision. So it is not a purview of discussion for today. So I think I have cleared all the doubts as far as those questions
Sir,
are.
one more. All these
Yes,
medical committees are in action everywhere, sir?
Yes, it should be in each district. As per MTP Act amendment, it is mentioned that each district should have their own medical board. They can opine patient of that very district.
Okay, sir. One more question, sir. And suppose if an young woman like 16, 17 years married, if she comes for MTP, can we do?
Of course, we can do.
Sir, please, these are all our future questions. Please don't answer.
Okay, then we will discuss.
Okay, ma'am.
Please.
Okay, ma'am. Okay, ma'am. Thank you. Thank you,
Thank
sir.
you. Thank
I
you
wish
so much.
both all the success.
Thank you, ma'am. So next we have Dr. Shirisha. She is the secretary of Warangal Obstetric Gynec Society, interested in high-risk pregnancy, adolescent health, and adolescent counseling. Welcome, Dr. Shirisha. Over to you.
Good evening, sir. And
Welcome.
today's
Good
my
evening.
question, sir. So, what are the violations of the Act commonly we see in the court? Are medical abortions also covered under the Act? And what are the forms to be filled and the provisions of personal privacy of the lady under the Act?
Yes. As far as violation of Act is concerned, place is not registered and termination is done. Person is not qualified and termination is done. And it is very much mandatory to take consent in prescribed form, that is form C. And if consent is not taken in form C, these are common violations of this Act. As far as medical abortion is concerned, this is accepted method for termination, and all the purview of MTP Act will be applicable in case of medical termination also. So to take consent in form C, to take opinion in form 1, it is also required in medical abortion. As far as different forms are concerned, so there are many forms as far as this MTP Act is concerned. One form is Form A. At the time of applying for registration of clinic, one has to go in that very Form A. If center is registered, then certificate of registration is given in Form B. It is prescribed form. Form C, just I mentioned, it is consent, and consent is to be taken in Form C. Of course, we will have to take one more consent, that is informed consent, because in Form C, it is simply mentioned that I give my permission to terminate my pregnancy. It is not informed consent. And in any intervention, we have to go with informed consent. So we will go with two consent, one informed consent and one consent in Form C. And as far as informed consent is concerned, I would like to mention it is available on Foxy website. You have to simply visit Foxy website, and under name Foxy Uniform Consent, there are 30 different consent available with 3 medical legal experts, Dr. Dilip Palke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent, and it is available on Foxy website. And in those consent, the consent to terminate pregnancy by medical method and by surgical method, consent is there. So you can download and you can use in your day-to-day practice. So that is Form C. Form D. Form D is opinion from medical board. So just we discuss about role of medical board. So when medical board will opine, he will opine in prescribed Form D. One more form is Form E. When pregnancy is more than 20 weeks and less than 24 weeks, opinion of 2 registered medical practitioners required, and it is to be formed, that very opinion, in Form E. There are some other forms also. Form 1, this is opinion up to 20 weeks of pregnancy, and it is by only 1 registered medical practitioner. Form 2 is monthly reporting. It is again prescribed form, and in that very form we have to report appropriate authority at the end of month within reasonable time. Form 3 is, we can call it MTP register, or we can call it admission register also. So once it is decided to terminate pregnancy of that very eligible patient, then all the information related to patient is to be entered in Form 3. Name, age, address, weeks of gestation, who registered medical practitioner opined to terminate, who terminated pregnancy, by which method pregnancy is terminated, which method of contraception adopted by patient after termination of pregnancy. So all these details are in Form 3. So these are some different forms as far as MTP Act is concerned.
Thank you, sir.
Yes, welcome, Madhuchandar. I had opportunity to visit Warangal in recent past, and Madhuchandar and Sirisa all were good hosts for me.
He's
at
the
that
president
time
of
my
Warangal
visit.
Society.
Warangal.
Yes, sir. And his interested fields are PCOS and high-risk pregnancy care. Very innovative CV, by the way. So, Madhu sir, if you're there. If
Dr.
not,
Madhu?
Shirisha, you can take over.
Yes,
Yeah,
Sirisha can take.
So the question is, who can be shown the documents of the lady and who is the authority on whose orders papers are to be shown? MTP form is submitted online to district authority. Then what about privacy? With OTC availability of MTP pills, where does the reporting on MTP stand? What is the role of gynae when such a lady comes with retained products?
Yes. So one by one we will go. Who can be shown document? There are only two conditions where we can open MTP register and we can go with all this detail of patient. One, if patient is working woman and if she wants a certificate to grant leave, then we can open that register and we can issue that very certificate. And under authority of law, person who is authorized by law can inspect that very document. And the chief district medical officer is appropriate authority as far as MTP Act is concerned. In case of any litigation, if investigation officer is conferred with power to investigate that very case, he can also inspect that register. So these are the conditions where this register can be inspected. MTP form is submitted online, whether it is online or whether it is physical. This is prescribed form, that is form 2. And in form 2, no personal identity of any patient is revealed. We go with only statistic. Say, for example, how many MTP done in your clinic last month, in month of May? Say, for example, 25. How many up to 12 weeks? Say, for example, 5. How many from 20 to 24 weeks? Say, for example, 4. So we go with statistics only. So there is no breach of confidentiality in that very form, whether it is online or whether it is physical. With OTC availability, so it is a big issue, but whenever patient goes directly to any pharma and they get this OTC, I mean over-the-counter termination of pregnancy pill, and when something happens, patient is not ready to lodge complaint against that very pharma. One thing. And second thing, they are smart enough. They will never issue bill, receipt. So it will be very difficult to prove also that whether they had dispensed that very drug without prescription of any registered medical practitioner. But as far as this complication related to that part is concerned, if patient has purchased OTC and she ended into retained product or any complication, of course we have to treat. And at the time of that, if she gives history of taking a pill by her own through this pharma or by any other clinic or so, we have to mention in history. If patient is willing to go to complain against that very pharma or person, then we can inform police. Otherwise, it is very difficult to go with this type of litigation or application against that very pharma, because it is difficult to prove also. But it can be taken on part of government or on association level only if government becomes very strict. Drugs and Food Department, which is authority as far as this pharmacy part is concerned, and if they become strict and if they verify how many OTC, I mean MTP pills that very pharmacy purchased and against which prescription they sold, if they become strict to inspect this type of register, then it will be a check. Otherwise, it is very difficult to check it. Yes, next.
Next, we have Dr. Meghna Rao, ma'am. She's a consultant obstetrician and gynecologist at Gayatri Hospital, professor of gynec lab surgeon, Foxy Karimnagar secretary, and she's been practicing for 12 years. So over to you, Dr. Meghna.
Welcome, Meghna madam.
Anybody may take the question, please.
From Karimnagar, anybody?
Requesting anyone present to please take
Any
the question.
panelist can take, no issue.
Can I,
Good
ma'am?
evening.
Oh, yes.
Yes,
Anybody,
can I
anybody
take
can.
Dr. Sandhya?
Oh, yes. Welcome, madam.
Sir, good evening, sir. Good evening, madam.
Yes. Good evening.
Lethal deformity detected in anomalies can MTP be done?
Yes, yes, very yes. Any lethal abnormality detected in fetus, pregnancy can be terminated at any given gestational age. But in this situation, if pregnancy is less than 24 weeks, with opinion of 2 registered medical practitioners, we will go with termination. If it is more than 24 weeks, then opinion of medical body is required. But this ground, lethal deformity, is a valid ground as far as termination of pregnancy is concerned.
Sir, and about non-lethal anomaly detected at 27 weeks, can MTP done under which provision? What is the legal procedure involved in that?
So, more than 24 weeks, only medical board can opine in case of congenital fetal anomaly which are incompatible with life of fetus. But if it is non-lethal, but if there is danger to patient for any reason, then you can terminate pregnancy under Section 5 of MTP Act. Under Section 5, this power is given to person who is eligible to terminate pregnancy irrespective of gestational age, not even 27 weeks, even more
Not
than
even-
27 weeks, then also. But burden of proof will be on shoulder of person who has terminated pregnancy to prove that it was immediate necessary to save life of patient to terminate pregnancy. So even pregnancy is very normal otherwise or non-lethal anomaly, but if life of patient is in danger, then one can terminate pregnancy. Say for example, pregnancy is otherwise normal, but patient is having malignant hypertension. And if we have to terminate pregnancy to save life of patient, we can
Yes.
terminate pregnancy. So in this type of situation, it is allowed.
Thank you, sir.
Welcome. Next.
Sir, I would add on that if there is no maternal complication and it is a non-lethal anomaly and they want abortion, can it be done?
No, no.
No.
There should be some indication. In one of the cases, court has very specifically mentioned that termination of pregnancy cannot be entertained on demand. It is not right of patient. It was very clearly mentioned. There should be some indication which are mentioned in MTP Act 1971. So if pregnancy is very normal, there is no danger to maternal health, and fetus has no anomaly or non-lethal anomaly, on that ground pregnancy cannot be terminated. If at all patient is willing to go for termination of pregnancy, they can seek permission from honorable court, and if permission is granted on part of honorable court, then only we can terminate pregnancy.
Sir, thank you, sir.
Welcome.
Thank you, sir. We have Dr. G.B. Madhavi, Professor of Obstetrics and Gynecology. She is a fetal medicine consultant at Sai Raja Diagnostics, Karimnagar, certified by IOTA and examiner for UG and PG. Madhavi, ma'am. Sujata, ma'am, would you please take this question? Please, Sujata, ma'am.
Good evening, sir.
Welcome, madam.
Thank you, Asha Jain ma'am. Question is, who gives consent in a major lady? Is partner consent required? Is a separate informed consent along with Form C required?
So as far as any major patient is concerned, when patient is major, when patient is mentally sound, only and only she can give consent for termination of her pregnancy, and no consent of anybody, including her partner, is required. So only consent of patient. As far as separate informed consent, just I mentioned prior also, because as far as consent in Form C, it is very simple mention that I give my permission to terminate my pregnancy. It is not informed consent. So we should go with informed consent, and just I mentioned, it is available on Foxy website.
Sir, one question, sir.
Yes, yes.
Sir, the patient is major. She's around 22 years and 19 weeks pregnancy. She came for termination.
Hmm.
And she's telling that my parents came for signature, husband he won't come. And there is no indication at all. Baby is fine. There is no abnormality.
Madam, when patient is major, no other consent is required. Patient herself will sign the document of consent.
Can we do, sir?
Definitely we can do. It is provision in MTP Act. Only and only patient who is major and mentally sound can give consent. If patient is minor or if patient is mentally challenged, then only consent of guardian is required. Otherwise, no consent of guardian is required.
Oh, thank you, sir.
Yes, welcome.
So now, Dr. Sujata ma'am, it's officially your question. So, ma'am is the director of Vijay Lakshmi Hospital at Nizamabad. So, over to you, ma'am.
Thank you, ma'am. My question is, any interesting cases with us learning for us on the mistakes we need to avoid, and your final minimum recommendation to avoid litigations in MTP, sir?
Yes, one case which happened in city of Ahmedabad only in 2003. Termination of pregnancy was done in 2003 with consent of patient. Form C, Form 1, everything was fine. In 2004, there was quarrel in the family, and it is usual story. When there is a quarrel in the family, she will lodge complaint against in-laws that termination of my pregnancy was forceful without my consent against my will. So in that very case, doctor was called in court of law to give all this document. So court asked Form C, Form 1, but doctor was so casual in his answer that it was OPD patient. I terminated pregnancy by medical method. So I do not preserve all this Form C, Form 1. And you won't believe, from court only. Court ordered to arrest doctor and doctor was put behind bar. After 3 days, there was compromise in the party. Case was withdrawn and then only doctor was out of bar after 3 days. So you cannot afford this like of practice, because once you have terminated pregnancy, you should observe all the provisions of MTP Act. Form C, that is consent. Form 1, that is opinion up to 20 weeks. If it is more than 20, less than 24 weeks, opinion in Form E. You have to maintain all those records at least for 5 years. And if at all there is a litigation, then you have, and if you are called as a witness in court of law, you have to produce all those records which you have preserved in court of law. You are under obligation. And so that is why my recommendation, first, center should be registered, person should be qualified, and all the provisions we have to strictly observe. That is consent in Form C, opinion in Form 1 or Form E, whichever the case may be, or if it is more than 24 weeks, then opinion from medical board. So whichever the provisions of MTP Act are concerned, we have to observe. Because Medical Termination of Pregnancy Act 1971 is doctor friendly. There are so many provisions in that very act in our favor. But if we do not use those provisions, then it would be troublesome for us if at all we are facing any litigation. So we should be very clear in this. Yes, next.
Next, we have Dr. Sushma Meda. She is the fetal medicine consultant at Sri Krishna Nursing Home, trained by Dr. Adi and certified by IOTA as well. So welcome, Dr. Sushma. I hope you are here.
Good evening, ma'am. Yes, ma'am.
Yes, welcome, Sushma.
Yes, please proceed.
Good evening, sir.
Yes.
Can't see you, ma'am.
Sorry, ma'am, I could not turn on the video.
No issue, chalo. If video
See
is
it, what is
fine.
wrong? Why madam is not able to turn on her video? Now you try. I've asked you to start video.
From my end, it is okay, ma'am.
Okay.
So there could be
Yes,
some
ma'am. Some
local
settings
problem.
in my phones. Some
Yes,
settings in my phone.
No issue. You can go with question.
If MTP of more than 24 weeks is done, and if the baby delivered is live, and to whom should the custody be given? And if the patient or relatives are not willing to take custody, and what next?
When we are going to terminate pregnancy more than 24 weeks, it is all likely that baby may come live. So at the time of taking consent, we have to explain this possibility, and we have to explain about custody of baby also, because till baby is live, we cannot abandon that baby as it is. So custody should be given to the patient or patient party, but many a time in this situation, they are not at all interested to take custody. So in this situation, we have two options. Either we can shift that very patient to NICU, because as far as government hospital part is concerned, no issue. They can straightway transfer that baby to NICU. But in private sector, who will bear cost of NICU when patients are not willing to go for further treatment with that very baby? So here comes role of police. We can inform police if we have taken consent or explain at the time of taking consent and during counseling that they will take custody, and if they are refusing to take custody, then we can very well go with police complaint. As far as prior feticide is concerned, as such, there is no guideline given in MTP Act or in this amendment also. So this is gray area again. There are a few countries. In that very country, it is compulsory, not advisable. It is compulsory to go for feticide first and then terminate pregnancy. But in India, there is no provision in MTP Act that prior feticide should be considered or not. So here comes role of IMA, FOXY, or other association. We should approach government to clarify this, and there should be amendment in this act. So in a lighter way, I appeal in my lecture also, if you vote me and if I am selected or elected as a President Foxy, I am going to this matter very seriously approaching government. Thank you. Next.
We have Dr. Naini. She is trained in medical diagnostic ultrasound. Today we have a lot of ultrasound people with us. She is the secretary of Foxy Karimnagar, organizing committee member of APCOG and TCOG 2016. She is a faculty at state and national conferences and has conducted many CMEs and workshops. Over to you, Dr. Naini.
Naini madam, is she there? Anybody from Karimnagar? If she is not there.
Hello, I'm Dr. Neelima from Karimnagar.
Yes, welcome, madam.
Thank you, sir. A 26-year-old third gravida with 2 previous living children having at 22 weeks of pregnancy for MTP with reason given failure of contraception. Can we do MTP or not?
No, we cannot, because indication of failure of contraception is available up to 20 weeks of pregnancy only. So here pregnancy is 22 weeks. So that ground cannot be availed as far as termination of pregnancy is concerned.
Thank you, sir.
We have Dr. Mridula Mahabal, ma'am. She's an assistant professor in obstetric gynae of Medical Institute of Medical Sciences from 2010 to 12. She was previous secretary of Nizamabad Society. Welcome, ma'am.
Hello, good evening, ma'am.
Yes,
good evening,
welcome,
ma'am and sir. Thank you for this opportunity. So I would like to ask this question. 19-year-old unmarried girl, she is brought to the hospital. She's in shock and she has brought by an ANM who has attempted her illegal abortion, criminal abortion at 3 months of pregnancy, and she was accompanied with her parents. On examination, patient is in shock, omentum is hanging throughout the vagina. So now what to be done? Whether we should first resuscitate or whether whether we would first file an FIR and wait for the police to come?
Naturally, we should resuscitate first, because in one of the case, Parmanand Katara, there was public interest litigation by this Parmanand Katara. And in that very case, court has very specifically mentioned, first you treat patient, all other legal formality afterwards. So in this situation, when patient is in shock, naturally we have to resuscitate and we have to go with laparotomy or whichever treatment should be done in this very given situation. And as far as information to the police is concerned or FIR is concerned, if patient is willing to lodge complaint, we can inform police. If patient is not willing to lodge complaint, then we cannot force patient to inform police.
So in that case, can we lodge a complaint against that ANM, sir, for that criminal abortion?
No, just I mentioned, if patient is not willing to lodge complaint against ANM, we cannot. It is privilege of patient only.
Okay, sir. If the same is a 17-year-old girl, then what will be the protocol, sir?
If she is 17, irrespective of her condition, whether she is in shock, whether she is not in shock, but once you came to know that she is pregnant and she is 17, that is less than 18, that is minor, you have to only 1 minute.
So here we should not attempt resuscitation, sir, for 17-year-old girl.
Pardon?
For 17-year-old girl, we will not do first resuscitation.
No, naturally we will go with resuscitation and treat patient. But in this situation, to inform police is compulsory.
Okay, even though
because
she
is
doesn't
minor.
want to. Okay.
She is minor, so it becomes a case of POXO under there is POXO 2012. So we have to inform police. It is very much mandatory.
Sir, how about married 17-year girl with pregnancy, sir?
Irrespective of her marital status, once she is minor, we have to inform police.
So when we inform the Commissioner of Family Welfare, maternal and childcare thing.
So either you inform police or you inform CWC.
But they were not cooperative, like they are married, she is conceived, we can't help it like that, the reply, sir.
So in this situation, many times police is not ready to give acknowledgement of information. So in this situation, it is better to inform CWC, and CWC will take charge of that very patient. They will convince them, they will inform police, whichever they have to go. But once we inform CWC, our role is over.
Yes, sir. If she is a minor, we have to inform whether she is married or unmarried, sir.
Irrespective of her marital status, POXO Act will apply when patient is minor.
Sir, thank you, sir.
Thank you, sir. Now we have Dr. Sandhya Rani, ma'am. She's been here patiently since the beginning. So welcome, ma'am, from Warangal Obstetric Gynec Society.
Yes, madam. Thank you, madam. Thank you for giving me this opportunity. And here the question is, a 22 years old unmarried girl came to the doctor with her a boyfriend and asking to have termination of 3.5 months pregnancy. And what to be done?
So if your center is registered, if you are qualified person, and if there is valid indication, you can terminate pregnancy. But in this situation, one word of caution I would like to mention. 22 years means she is major, but she is unmarried. So in one of the cases, it happened in state of Gujarat only. In the same situation, pregnancy was terminated. After 6 months, police came that that patient has lodged complaint against that boy who had given promise of marriage. And against that promise of marriage, she had given consent to go for sexual life. So now he is declining of getting married, and so this is a case of rape. Police came to gynecologist and told that why you didn't inform police. So in this situation, not to end up into this type of problem in future, when we take consent from patient, when patient is major, we have to get it written by patient herself that it is result of consensual sex. I have no complaint against anybody. I do not want to inform police, because at that point of time, She is very clear. She has no complaint against that very boy. So she is very clear. And any gynecologist will never predict that she is going to complain that very boy in future. So he will inform police. So not necessary to inform police if she has given in writing like this. So we should be very careful when we are dealing with this type of situation, major but unmarried.
Sir. Thank you, sir.
Yes, welcome.
We have Dr. Kolluri Radha ma'am, General Secretary Foxy of Karimnagar branch. So, ma'am, if you could take this question, or anybody from Karimnagar can take it. Dr. Neelima? Yeah.
A 9-year-old patient conceived with ART, triplets, advised fetal reduction. Should center be registered for MTP? Does it come under preview of MTP Act? Which forms are to be filled?
So first thing in this situation, as far as fetal reduction is concerned, it is not termination of pregnancy because pregnancy is continued. So it will not come in purview of MTP Act. So this procedure can be done even at unregistered place also. And once it is not in purview of MTP Act, then no necessary to go with any form.
Finally is Dr. Nilima's question. Her areas of interest are fetal medicine and high-risk obstetrics. Madam is the treasurer of Karimnagar Society. Yes, ma'am.
Sir, a center registered person qualified 6 weeks of pregnancy wants MTP and has come alone. Will you do medical method MTP if she asks for it? If she wants surgical abortion, will you do it? Am I audible? Am I audible?
Yeah, you are audible, Dr. Nilima. Sir has just received a call. So, sir,
Yes,
the question
yes,
is
welcome,
waiting for you, sir.
Welcome.
So if a person comes alone at 6 weeks, can we do medical method of MTP? And will it be the same if she wants the surgical abortion?
So as far as medical method is concerned, there is no issue. We can very well go with termination of pregnancy if center is registered, person is qualified. But as far as surgical part is concerned, of course, patient is eligible to give consent if she is major, mentally sound. But if at all some complications happens, because in one of the cases it was happened, it was surgical termination, patient was alone, and it ended into perforation, blood transfusion was required. Of course, it was managed at that very hospital. But then relatives were informed and relatives were very angry. Why you didn't inform prior? And case was filed against doctor. Of course, in that very case, case was decided in favor of a doctor because when patient is major, no need to inform anybody. But as far as surgical part is concerned, if at all we ended into this type of complication, not to face situation like this, it is always better. Somebody should be there waiting outside operation theater who is known to that very patient. So if in situation of any complication or further management, say for example, blood transfusion or laparotomy or anything, then we can deal with situation accordingly.
And
Medical
one more.
method, yes, ma'am.
Regarding the terminology, if a patient comes at 23 weeks with inevitable miscarriage, so does the terminology, shall we need to fill that in the MTP register book, sir?
So, whenever there is danger to patient's life, you can terminate pregnancy irrespective of this purview of MTP Act. Under Section 5 of MTP Act, we can terminate.
We can terminate, sir, but does it fall under the word MTP, sir? So it has come naturally, she has aborted. Then we should use the same term, sir. We should use the same word, medical termination of
It is inevitable abortion, na?
Yes. So it is not medical termination.
When it is complication of pregnancy, whether it is blighted ovum, missed abortion, incomplete abortion, inevitable abortion, all these conditions do not come in purview of MTP Act. No formality of MTP Act. You can straightway deal with situation accordingly.
But we need to document in the MTP register, sir.
No, not at all. It is not MTP.
It is not MTP.
You are dealing with complication of pregnancy.
Okay, that is what my doubt, sir. So I had
if pregnancy is very live, then only it comes in purview of MTP.
Okay. So we need not write it in the MTP register book. She came with
not at all.
Okay, sir.
Any complication of pregnancy you can deal with accordingly, and no formality of MTP Act.
Okay, thank you, sir.
Anybody wants to ask any other question?
Ma'am, I want to ask. I'm Dr. Aparna.
Yeah, please proceed.
Sir, I want to ask when a patient can ask for a termination of pregnancy at 19 weeks on the basis of contraceptive failure, how we can rule out regarding it was not a sex diagnosis?
So it is very difficult, but up to 20 weeks, she can avail indication of failure of contraception as per amendment came in 2021. As far as that very danger, so we have to inquire about her past obstetric history. If she is having one female child or more than one female children, then these are the vulnerable group of patients. They might have gone to somebody else for sex determination, and if it could be female, and they might have come to us for termination of pregnancy with ground of this failure of contraception. But it is very difficult to judge whether it is genuine indication as far as her problem is concerned, or whether she has contacted anybody and it is selected female feticide.
In that cases, if we are asking the patient, we are helping her out by terminating the pregnancy, and at the same time we are going for bilateral tubectomy.
Yes, in one of the situation, very recently this was happened. There was phone call from one Foxian, sir, this is the situation, and I advise her, please inquire. So she had 2 female children, so it was all likely that she might have gone for determination, but she was willing to go for bilateral tubal ligation. And in that very situation, if you go with termination of pregnancy, doesn't matter, because if she is willing to go for tubal ligation, it is all likely that we can have defense in court of law if at all we are faced this situation.
Okay, sir. Thank you, sir.
Anybody else has any question? Anybody on the panel has any question?
On panel or any delegates who have joined can also ask. Otherwise, it is my humble appeal to endorse my candidature for post of President Foxy election year 2024. Considering my seniority, sincerity, dedication, and easily availability to any Foxian friend in any medical legal crisis. So consider all these points and please endorse. Election would be from 1st August to 10 August, 5 p.m. 10 August. So please vote in my favor and please make others also request on my behalf to vote for me. Thank you. Thank you.
Thank you, sir. Definitely we will encourage, sir. Definitely, sir.
Thank you. Thank you.
All the best, sir.
And one more appeal on behalf of Dr. Asha Jain also. She is going to contest for Food, Drug, Medico, Surgical Equipment Committee, FOXY. And in this situation, President and Secretary will have to vote on behalf of society. So all the President and Secretary are requested to cast their vote in favor of Dr. Asha Jain. She is a very hard-working lady. She is working in this series with me since long, more than 2 years. So, and she is very meticulous organizer as far as any conferences or any workshops are concerned. So she is very eligible person for this post. I request on her behalf to endorse her candidature and to vote for her.
Thank you, sir. Definitely, we will encourage Madam. Sir, Madam is like very dynamic, sir.
Yes, welcome.
Thank you, sir. Thank you.
Thank you.
Thank you,
Thank
sir.
you so much. Please vote for sir and vote for me. And
Madam,
Gauri
the
ma'am,
questions
we
are,
can.
Madam, questions are very nice, Madam, without any discomfort to the like panel. You prepared very well. Nice questions, Madam.
Thank you.
The
Thank you
reverse
so
panel
much.
is very good. Yes, ma'am.
Thank you. Gauri
Thank
Shri ma'am is there, ma'am. Would you like to say something? We used your presentation and the program finally ran well. So Gauri ma'am, if you would like to say something. And we also have our guest of honor, ma'am, still with us. So ma'am, if you would like to say something. Gauri
Namaste, ma'am. Thank you very much. Actually, there was a very poor connection because we had heavy rains and all. So there is a lot of disturbance in the network position here. And thank you very much, Swarupa madam. You have presented very nicely. And wherever I wanted to skip, you elaborated. So that is the reason why it has become so elaborated and it is so vast. But anyway, I think I have given my best. And
ma'am, you really did a wonderful job.
Thank
And
you very
thank
much.
you for that presentation. Because of it, the program went without a hitch. So thank you so much.
Yes, actually, I got prepared, but there was a lot of disturbance. That's the reason why I wanted to give some time so that after the panel.
So
Your
just
presentation
like
speaks it
any
all.
Gauri Sri madam,
Yes,
just like any operatic mishap, it
Sir.
may happen. Network issues are concerned, but you had prepared a very good presentation, and
Yes, it was great.
Swarupa madam has taken over very nicely. So thank you
Yes,
both
sir.
of you.
Thank you, sir. Thank you very much. We support you, sir. We support Asha madam also during the next coming elections. And thank you very much for giving the opportunity. And I see that next time I will not have this hitches in my presentation and all.
And this
Thank
series will
you.
continue.
Thank you, ma'am.
So next Tuesday we are going
Patel,
to.
sir.
Yes, welcome, madam.
Yeah,
Patel, sir, thank you,
actually,
sir.
we are
Asha ma'am,
privileged.
thank you so much for the opportunity.
Yes,
Thank you.
welcome. Welcome.
Thank
Always
you.
welcome.
We've met so often, I almost feel like we have been together, Dr. Shirisha.
Yes, ma'am.
So
Yes, ma'am. I was
all
so
the
attached to you
delegates
also.
and faculty who have joined, and next Tuesday, the same way we are with 5 societies of Kerala, and in reverse panel we are going to discuss counseling and consent. So anybody interested may join. Link will be available in the group.
Sure.
Okay,
Sir,
sir.
I'll take
Thank
the
you. Thank you, sir.
opportunity of this platform. Your topic here, your lecture here in Warangal regarding this MTP was amazing and excellent talk it is. And all our members are really happy with the talk. It was so like all the queries and doubts are being clarified, sir. And you're also too patient to clarify everybody's doubts. Thanks for all your patience.
So
Thank you.
Thank
yourself
you.
and
You know,
Madhu,
I have,
there.
as the convener, I have one thing to say. The program link did not work. I have shared the YouTube link. I will be sharing it after the program as well. The same link will have the recording. So please share it again, and you can write that message that this will have the, recording link as well. So
Sure,
thank
ma'am.
you
Thank
so
you.
much. Thank
So,
you.
Patel,
All
sir, last
faculty.
time I had the privilege of attending the 100th episode of
thank
this
you,
Happy
madam.
Learning,
Yes,
and
yes.
foreseeing to attend your 200th episode also, sir.
Welcome, madam.
All the
Always
very
welcome.
best.
Welcome, ma'am.
Welcome.
All the very best to you and ma'am. We are with you,
Yes.
sir and ma'am. Yes.
Yes,
Thank you.
Thank you, sir.
Thank you.
Thank you
sir.
very much, sir.
And
All
thank
the
you, ma'am.
best.
So, Asha, we
I'm
can.
Dr. Vijaya. Hello,
Yes,
sir.
welcome, madam.
Yes, sir. Thank you.
Yeah.
And all the best. All the very
Thank you
best,
very
sir. We
much. Thank
expect
you so much,
positive.
sir.
Thank you,
and
Vijay
very
ma'am.
all the best.
Thank you, madam.
Thank you. Namaskar, Shubh Ratri, and we meet again next Tuesday. Tomorrow, I have my searchlight. I will be sending you details, and it's on induction of labor. So I invite all of you to that as well.
Thank you, madam. Definitely we will attend.
Thank you. Thank you so much. Thank you, Corona Remedies, for being our academic partners and being with us all the time. Thank you very much, delegates who have participated and made the program worthwhile. And thank you all respected faculty for sparing your time, because time is life and you have really given that to us. Thank you so much. Thank you. See you again.
Thank you, sir.